Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Martin Dalton, who is a professor of surgery at Mercer University School of Medicine and also Dean Emeritus. And as a special treat, I have my son, Joey Robinson, who's a medical student at Mercer University. So tonight we're going to have a discussion about young doctor, old doctor. And I don't know if who we can tell who's, maybe I'm an old doctor, but sort of a senior, mature doctor, and just some of the challenges that are faced as one goes through one's career. So maybe we can have this little interchange. And now, Dr. Dalton, maybe we can start out by talking about some of the changes you've seen in your career in medicine. And do you have any? What did it used to be like in the old days to be a medical student? And what are some things you've seen happen during your career?
I would say the biggest change is there's much more information that students have to be aware of and responsible for today as compared to my day some 5 decades ago. And it's all for the good, because the more information you have, the better doctor you are, and the better you'll take care of your patients, which is your responsibility. Don't forget that. That's the main thing that you're here to learn, is how to take care of sick people. It's that simple. But that's much more information and much less, I would say, ability to sort through that we had, and you have much more of an ability to cut to the chase of what you really need to know with all of the accessory things you have at your disposal. The other big thing is really the work hours, the dedication has to be constantly monitored, and you have to spend more time delegating responsibility than taking responsibility. But I would say in general, the medical education of today is vastly superior to what I experienced as a medical student. What do you think?
I think so. We're doing a good job. I can only speak through my Mercer education. We've got an excellent patient contact, just seeing a lot of patients.
You start earlier. I mean, yeah. Isn't that correct? When did you start seeing patients, Joey?
Right. We start seeing real patients in the 3rd year, but we see standardized patients who were more or less actors in our 1st and 2nd years. And you always know going in they're not a real patient, and so when you first see the patient, it's not the same impression you get seeing a patient with that particular disease in the 3rd year when they actually have it. But I think just doing that little practice routine allows you to pick up those sort of cues to see if someone's really sick or not when you see them, and you can make some sort of determination like that just by walking in the room and seeing the patient from a distance before even examining or taking a history.
Now, Dr. Dalton, one of the things that Mercer prides itself on, I think, is the idea they have slightly different kind of teaching profile than other schools, do they not? I mean, there's sort of a problem-oriented, less didactic. Is that a fair statement? And
you're absolutely right. It's very different. The typical medical education is you start out as a freshman and you go through anatomy and physiology and pathology and all of the sciences, and then by the 3rd year you actually see patients. At Mercer, it's a tutorial system, and it's much more easily indoctrinated into neophyte students. For instance, you don't study the anatomy of the heart, you study heart disease, both acquired and congenital, and spend 6 weeks, 8 weeks?
6 weeks.
6 weeks, and during that time the students meet with a mentor, a preceptor, in a small room with no more than 6 or 7 students per group. And you go into all phases of heart disease and blood vessel disease, and you feel aware of your superiority of actually learning something that's definitive, rather than just memorizing as we had to do the origin and insertion of all the hundreds of muscles in the body, you were learning things you could put to practical use. And these tutorials and the problem-based learning thing has worked out very well. The students are acclimate more quickly. They tend to do better on their USMLE tests that all take.
And I think that's one thing Mercer prides itself on. The scores have really, at least from a statistical point of view, they've come up a lot with the students, so that the scores are really, the education impact has been substantial compared with other places.
The true measure would be how our students compare with students from other prestigious medical schools around the country, and they stack up very well. We have reports of residents that have been students at Mercer. They've gone into everything as varied from pediatric neurosurgery all the way to family medicine and pediatrics as a general specialty. But this tells us that we're doing the right thing.
Well, I think we can discuss medical education a little bit, but one of the things as by getting into my senior decade here is the idea of rote memory. That's the traditional way that things were taught, the idea that you can memorize something and then that's the end of it. I mean, I think we have to realize that the way that science and medicine are developing, what you've memorized today may be wrong tomorrow. Is that a fair statement?
You've got to be flexible, that's for sure. There's so much to learn and so little time to learn it, and you are responsible for it, both in taking care of your patients in your residency, as well as the various testing measures that you have to pass. The United States Medical Licensing Exam is taken after the second year, and then the Part 2 is taken before you graduate from medical school. So there's a lot of testing to be accomplished, a lot of memorization, but I think the difference at Mercer, rather than traditional medical school curricula, is that they are much more prone to use the information in a practical sense. That is, a sense they're learning things to take care of sick people, which is why they're in medical school.
Well, now, Joey, as a medical student, are the young medical students nervous about tests? Is that a fair statement?
I believe that's a fair statement, yeah.
So you have a lot of tests to take, do you not? How does that work in regards to the tests these days?
There's just a ton of tests to take. You could sort of categorize them. You have your sort of small tests that come along every once in a while, and you also have your big, as Dr. Dalton was alluding to, the Step 1 and Step 2 of the USMLE, and those scores are more national. They're supposed to rank people across the United States how they do on those scores from those tests.
So there's a sense of competition, really, as the young doctors are making their way through. People are trying to decide what specialty they'd like to go into, and it's very competitive, and there's test taking, and it's really quite a jungle in a way. Is that an understatement?
Correct. Yeah.
Trying to decide what to do and where to do it, and that's very complicated process, is it not? And what are some things young doctors and medical school students worry about these days? What are things that they think about?
Well, the big thing, as you alluded to, is residency. Everyone's worried about where am I going to go for residency? What am I going to do it in? But they're also worried about more day-to-day housekeeping type stuff. How is for example, I'm on the pediatric outpatient clinic right now. It's not too strenuous. I mostly deal with sick children and well children, but even then you'll go to whoever has done the outpatient clinic before and ask them for advice. Hey, how should I present to the resident this week? How do they like that sort of thing? So there's stress even with uncomplicated tasks.
Yes. Well, it's really quite a journey. I'm trying to remember my days in medical school, which were many years ago. But we were pretty much under the thrall. At least I was in medical school in Charlottesville, and it was very restrictive situation. People were very kind of kept away from patients a little bit. But I think you get a lot of patient exposure, do you not, these days? Yes. And that's to the good. Now, Dr. Dalton, I notice you have a book here about, maybe you could discuss this a little bit. We've got a book about Mercer Medical School that you've written. Is that right? Maybe you could just hold that up here. We can talk about that, about how a certain pride of ownership, I hope, in that book.
As I prepared to resign as dean and continue with the Department of Surgery, President Underwood gave me a year's sabbatical, and I'd always had the intent to try to pen the history of the medical school. The first students entered in 1982, but that seems like relatively recent history. But you have to think that a number of those people that participated over the years are no longer with us, so they were rapidly disappearing. So I seized the opportunity to go to the archives with the help of the archivist at Mercer Medical School Library and research all the information available and put it together in a time sequence, beginning with the entry of the students in 1982. But I would preface that by saying that a very prominent surgeon, Milford Hatcher, conceived the idea of a medical school in Macon in 1965.
Did he?
So it took 17 years for this to percolate through the system to get state funding, which we are a quasi-public/private medical school. But without the state funding, Mercer Medical School could not have existed. So we went through all of that and the ramifications of the political scene, the effectiveness of lobbyists in the General Assembly, finding faculty. They went through 5 deans in the first 7 years of the medical school, for instance. A lot of politics, a lot of recurring problems that had to be resolved. And I like to think of Mercer Medical School as being semi-miraculous, that it is in existence and persevering and prospering and has established itself as an icon in medical education, where our students are gleefully accepted to almost any school to which they apply.
Yes. Well, to me, one of the things, at least I'll make this comment, about the amount of money that goes into medical education. It's a very small percentage of the total amount of money that's invested in the American healthcare system, and it's just a very small number. It hasn't increased, it's flatlining, and it would be very important to be able to make those numbers increase. And we were discussing this earlier. One of the choke points in medical education are the shortage of residencies.
Absolutely.
And particularly in Georgia, is that correct? We have
the new school starting in Athens. There's an osteopathic school in the suburbs of Atlanta. There are several hundred additional students that will finish Georgia medical schools that have no place to go for training as a resident in surgery or pediatrics or whatever. And this has got to be remedied if we're going to move forward. There is, as you know, a predicted horrendous shortage of physicians starting in less than 10 years. And in 20 years, we may be some 200,000 physicians short that we desperately need. And we can graduate them from medical school, but if they can't go to a residency, it's all for naught. So that's the principal thing. And that has to be done through the state government as well as the federal government. The CMS, the Center for Medicare and Medicaid Management, has got to be convinced that we have to fund these additional residents and get them trained and established.
Now, is there a relationship between the societal need for, let's say, orthopedic surgeons, to pick that example, or pediatricians or thoracic surgeons? How do we get the correct number of doctors in the correct place? Is there some methodology? Do you have a comment about that? I mean, how does, let's say, cardiovascular surgeons, how are the number of cardiovascular surgeons in the country regulated?
They have a fixed number of residents that they can accept. And once that's filled, there are no additional spots. And they try to predict the need as contrasted to the applicants to the residency program so that no one would start and finish, say, a protracted residency in cardiothoracic surgery and still not be able to find a job when they get through.
So there is some kind of need relationship out there where I don't know if the public understands the way that residencies are approved. It's a really complicated, shall I say, Byzantine process. It's very heavy in regulation and I guess oversight and lots of complexities. And I think you've mentioned earlier about what if a program is disapproved, it's a pretty catastrophic event, and lots of tension in medical education about that.
Oh, you're absolutely right. That's just the way situation rounds itself out. I don't know what the ultimate solution would be, but we have this horrendous doctor shortage facing us, and something's got to be done.
And a lot of this, I think, just to make the statement, there are many young ladies that are entering medical school. They want to be physicians. In fact, I have a very beautiful daughter-in-law who's doing that. But we have as they pursue their career paths, there are interruptions for family issues, and so in many ways, their ability to function in the same pace as a male physician is somewhat reduced, appropriately so, and that's creating some kind of resource misapplication. Is that fair to say, Dr. Dalton? I mean, we need to respond to that and have more training programs.
Right. And we're still getting accustomed to the fact that nationwide, including Mercer, half the medical students are women. That has come about in the last decade. And that has led to a lot of rearrangement of various residencies as to which women would choose over men. And naturally, that has to be worked out at some level. And the only safeguard is the number of resident applications and the number of residency slots that are available.
So it's a complicated process. And let's see, what residencies do the ladies like? I think they like.
They tend to gravitate toward positions that would be less indoctrination, less physical activity. Like we have currently 40% of our surgery residents are women, and heretofore we had thought maybe women did not want to take the task of, which sometimes can be rather onerous, of being a general surgeon, say on trauma call and general surgery emergencies, up all night, that sort of thing. But it turns out they're gung-ho to do that.
Well, that's an interesting story, isn't it? So, I mean, we have a new world out there, and that's good. And I think the whole medical establishment is responding to this. And Joey, in your class, you've got how many ladies? Shall I use that word, or what's a good word? Ladies sounds good to me.
I'd say about half men, half women, somewhere in there.
And are many people married and older in your class? Do you have an older group in a way?
There's a fair amount that are married. Some are older that did something else before starting medical school for many years. It just depends on the person. There's a large variety.
And one of the things that happens is that students these days wind up with huge debts, for their education. Mm-hmm. Is that right? That's a big issue, and trying to pay that money back turns out to be a big problem. Have you heard your fellow students discuss that? It's a tough thing, isn't it? I mean,
yeah, that's one of the frequent topics discussed in the student lounge is debt repayment and that sort of thing.
Well, let's see. Do people how does a young doctor pick, or a young student pick what specialty they want to go into? Is there any? It seems to me the choice is being hurried up a lot. And I think in my day, one had a little time. There would be a traditional internship and sort of think things over. And that's just pretty much impossible, isn't it? You have to make your determination early on. That's a stressful thing, isn't it?
Usually, yeah. Usually people sort of filter their decision. Do you want to do some sort of surgery or not some sort of surgery? And then people usually go from there.
Well, that makes it a little bit different, and people go for rotations in different places. And
right.
How does that work exactly?
You have to apply either through the visiting student application service or just individually to schools to do an away rotation at their school. It's a little bit frustrating. I'm personally in the process of doing this right now, and many of them have not listed when I'll be able to do that next year, so I just sort of have to leave these dates open. So you do that and you go there, and it's almost like a month-long job interview where you'll be there and you'll be on call, and there's a rule like you can work no more than 30 hours, I believe, in a row of clinic duty as a resident. However, that same rule does not apply to medical students. So,
oh, really? So they'll work you more, is that right?
No, you'll say, I would gladly work another 6 or 8 hours, clinic duty or seeing patients or doing that sort of thing, when really you're dead tired and a nap would be good.
Yes. Well, Dr. Dalton, how do you pick your surgery residents? I mean, what is that process? And that's, maybe you could make some comments about that, about how doctors get to where they need to go.
Well, first of all, the residents selected into the program are the lifeblood of the program. And as surgery faculty, that's the most important thing we do, is finding residents that would like to come, that we would like to have. It's a two-way street.
Yes.
And we take 4 residents in our program each year, beginning July 1. And of that group, selected from 40 applicants. So it's a tedious process for the entire faculty to designate time to interview 40 applicants over the span, as Joey said, 2 or 3 months of interview season. But we managed to get it done. We actually grade the entire group we're considering and work from there. We receive input from residents that had finished the program, faculty and other institutions that we know personally. And of course, with 6 or 8 faculty members interviewing, we have a lot of opinions.
Yes.
So it tends to gradate, and actually we list the entire group, 1 through 40, as to what we would like to have. This year, we went down to number 17, picking our 4 residents, which is really pretty darn good.
So really the surgery program is getting many really good applicants, and I think in some ways I'll just give you the credit for that over the years, and certainly Dr. Nakayama is doing great, but
yes,
he's following in your footsteps. So you really try and probe the character of a potential resident to see what you'll
well, they have the test that Joey alluded to. That's one thing, the test grades, which gives you a little bit of information on their intellect. We look for well-rounded individuals. We look for people that have persevered, perhaps despite adversity. We look for individuals that are dedicated to hard work ethic, which is the backbone of surgery residency training. It's hard work.
Yes, it's very hard,
and
isn't it?
mental acuity is figured in there. And then there's sort of nebulous things we look into that are difficult to gradate. But we end up with a pretty good picture of how this person would fit in with our program. We want people to come to our program that would be happy to be participating.
Yes.
And that way they can accomplish much more than if they're definite. But it's a tedious process. But as I said, the most important thing we do is selecting the residents into the program.
Yes. And the journey can be stressful. I mean, in going into something like surgery, many people, or at least some people, have adjustment difficulties. Things can happen making their way through, because there's a tremendous amount of responsibility that a surgeon has. Is that correct? I mean, it's
awesome.
And the doctor-patient relationship is something that maybe you could speak to that a little bit. I mean, it's the keystone of the whole American medical community. Could you talk about that?
Well, perhaps the most important attribute of a surgery resident is his or her ability to communicate effectively. You've got to take care of the patients. You've got to work with other specialty-oriented physicians. You've got to worry about the referring doctor and where that relationship is going. So we spend a lot of time teaching communication skills and things that we call professionalism. That's how you conduct yourself with patients, both good news and bad news. I mean, some patients are going to thrive, others are unfortunately going to have complications. Death is always in the wings, and you have to deal with many emotional situations, and we try to prepare them to do just that.
Now, Joey, isn't there a way, or you at least you discussed a little bit about how to give people bad news? Do you do that at Mercer? I mean,
yeah, we had a whole clinical skills session devoted towards delivering bad news.
Really?
And I won't say this because there may be future Mercer medical students out there listening in, but basically it was just a bad situation, and you had to go in and talk to I think it was always women because they'd be harder to talk to, I guess.
These were actors you were talking
to. Actors, yes. And you'd go in and you'd talk to them and you'd say, it looks like, you're not going to make it. And you'd sort of guide them through this process and have them accept the news as much as possible and deal with all sorts of personal issues they may be having to deal with.
Well, I can remember in my day, I was through a fairly traditional medical school training, pretty didactic, and then I started my internship at Grady many, many years ago, and the first day on the job I had that responsibility, and it was really quite a shock just to suddenly, never having done that, to be able to communicate. But that's it's a really important part of being a doctor, is being able to be empathetic and to help people when they go through the difficult times that happen. I mean, I think it's important. I mean, maybe Dr. Dalton can comment about this. It can be so stressful for a young doctor to many of the tragedies that happen. I mean, that's very difficult to go through that sometimes with your patients. Very tough.
It can be an emotional whirlwind. You go to one patient's room and he's recovering from sophisticated cancer surgery, and the next room someone is dying of an infection or complication, and you have to address all of this. Surgeons in particular, and physicians in general, have to be fairly good actors. Do they stress that in your criticism of the professionalism and the treatment of delivering bad news? That you've got to take on the mold of sad news versus good news.
Right.
I think patients pick up on the fact that if you're insincere.
Right. I wouldn't say actor, because you've got to convey that you mean, you're sorry for what they're having to go through, and you've really done everything you can, and you wish it would have turned out a different way, but unfortunately this is how it had to be, and you'll be there to accompany them until they may expire. So you definitely have to project all those sorts of traits, and it's not just dealing with the critically ill and projecting this professionalism image. It's just dealing with everyday patients as well, and trying to maintain the integrity of the profession.
Well, I'll make this point, and maybe Dr. Dalton can talk about it too. One of the tremendous difficulties or frustrations as being a surgeon is when everything you've done the perfect operation and they have a bad result. So that's one of the things that we have to deal with. It's a very very stressful, and I think one of the things that happens is that the desire for perfection and perfect outcomes is not always possible to have that. Even so, it's very emotionally stressful, is it not, Dr. Dalton?
Oh, you're absolutely right. It's an emotional whirlwind, it's top to bottom. Everything you do can be misconstrued or mismanaged or misallocated. I guess acting is too severe a word, but you've got to take on the mood of the patient that you're dealing with at that moment.
Right. Mm-hmm.
Well, there are a lot of things to talk about. I don't know how much time we have left, but I'll just make some general comments. We have, I think, Dr. Dalton, you're a senior guy here. Maybe I'm somewhat in the middle. We have Joey, you're coming along. But we have a tradition that this is part of our profession. And we have to be careful about external forces that are moving in, I guess, from many, many directions toward our citadel, if you want to think about it, our sense of responsibility for our patients. And it's really important to be the patient's advocate. I mean, do you get the picture that that's one of the things that you have a responsibility for, Joey, being for your patient and putting him first?
Yeah, absolutely. If you think the patient needs something, even at the setting I'm in right now, when I go in and see the patient, if I think they require further testing, I'll make sure I tell that to the resident. If the resident doesn't think so, I'll mention it to another resident. Or if I think they're being treated unnecessarily for whatever they're in for, I'll try to bring out a discussion as to why we're going to treat them for something when it may be a little bit too extreme to treat them.
Well, I think that's a good note to end on, and I hope we can encourage maybe some young people out there to think about medicine as a career. And I thank both of you for being with us this evening. Thank you.
Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.